Okay, so as we are getting started, the first question is, since you are the expert on pandemic preparedness, uh, we know that the response to this pandemic has been less than adequate. And so in the future, how do you think the medical supply chains should be changed to prevent another major shortage of PPE, like the kind we saw in March in New York last year?
Well, first of all, thank you very much for having me with you today. I appreciate this. A couple of qualifications before we start. I do have one thing I need to disclose, and that is the more I learn about this virus, the less I think I know about it. So from that standpoint, you can take any of my comments for what they're worth. The second thing is what I guess I would just start by saying perspective. We have never had a pandemic like this in modern human lifetime. When we talk about influenza pandemics, which have historically been the pandemics, there have been 10 influenza pandemics just in the last 250 years. And when you look at those, they started all times of the year. Of those 10, 2 started in our North American winter, 3 in our spring, 2 in our summer, and 3 in the fall. In virtually every situation, the virus first appeared in an area of the world and spread quickly, such that it really covered the globe, even before global travel was anything like it is today, in short order. And what was remarkable, though, however, almost in every instance, the virus really did all of its damage in 6 to 10 weeks in a given geographic area, and then it was gone. If you look back on 2009 H1N1, the last influenza pandemic, it arrived in North America in early to mid-March, peaked out late April, early May. Despite no mitigation strategies put in place by us as humans, the virus really virtually almost disappeared through the summer months. It started to show back up again in North America in August, late August of 2009, increased substantially. Again, no real mitigation strategies in place. We had no vaccine at the time. It peaked out in late September and then came down quite dramatically in October. Well, vaccine didn't arrive in any meaningful way till the end of October, early November. I mean, the pandemic was already gone. So we had 2 different waves that were short-lived that then basically left us. That's a big difference here. What we're seeing with this pandemic has been really, it's what I call shifting baseline. Remember back in April when the house was on fire in New York. Southern California was hit. Detroit, Chicago, Atlanta, some urban areas like that seemed to be on fire. Around the world, we saw it in Italy, northern Italy, in the Milano area. And we saw it in other areas of the world like that. And then suddenly case numbers went down. In the United States, we went from 32,000 cases a day in April, which we thought was the worst it could get, down to 22,000 cases a day by Memorial Day. And we hit kind of that new bottom, and we thought we were going to keep going down. The upper Midwest, actually, at that time, we had our highest number of cases when much of the rest of the country was enjoying a relative absence of case increases. And then we saw all across the southern belt of this country, from Southern California to Georgia, Florida, major increase in cases. In July, we got up to about 72,000 cases a day. Again, a new high. But then what happened? Case numbers came down again. We got down to almost 27,000 cases around Labor Day, and everybody thought, wow, see, this is over with, it's done, kind of a new normal. That, 26,000 cases would have been a real challenge back in April. And then what happened? The upper Midwest lit up again. And between mid-September and early November, we were a house on fire in Montana, North and South Dakota, Nebraska, Iowa, Minnesota, Wisconsin, Illinois. And while we didn't have that large a percentage of the U.S. population, we contributed a lot of cases. Then we started getting better again in November. And by mid-November, our cases were coming down all over the upper Midwest. That same southern region lit on fire again, from LA all the way across to Georgia, Florida, and that entire southern section of states, which is where we're at now. And so it's a very different kind of epidemiology than past pandemics. So anything we refer to about preparing for a pandemic, remember, all of it was really to prepare for influenza. which, as I just described to you, is a totally different situation that we're seeing now with this virus. And I fear that this virus isn't going to go away. Unlike influenza, which does become a seasonal flu virus, so it's still here, but it's in a very different picture. When you think about influenza, think about this. In the last 10 years in this country, seasonal flu has killed somewhere between 12 to 60,000 people. Wide range, but 12 to 60,000 people in 10 years. We're now at 340,000 deaths with COVID in the last 12 months. Right now in the United States, COVID-19 deaths exceed the next three leading causes of death combined. It's a very different kind of situation. Now, on a worldwide basis, much of the same is happening with the exception of what's happened in Asia. When you think about this issue right now, it's clear that there's big differences in the way we handle this. The science isn't any different here than it is in Asia. But if you look at, for example, New Zealand, it's the same size as LA County, same population size. They've had 29 deaths in New Zealand as of today. LA County's had over 29,000 deaths. Same size population. What's different? It's how we handle it. So I think, in short, to answer your question, the virus is going to be very different with this one. This doesn't necessarily give us any instruction about what future pandemics will be like. If we had another influenza pandemic, which we will, I expect it to be more like old influenza pandemics. This one is a bird unto its own. And I think that this is going to be one that will be with us for a long, long time to come. And how we interact, what happens with it, what we experience, how we plan for it is going to be so different than anything else. I can't say that there is a sense of just what is pandemic preparedness.
I have a question about kind of the supply chain lines. I know in the past, in some of your books and podcasts, you've talked about us being too dependent on other countries for just generic medicines and things like that. Do you think that that will change given what happened at the beginning of this pandemic? Do you think that maybe opened our eyes to that more? Or do you foresee that being the same going forward?
Yeah, again, great question. First of all, let's just take a step back and look at what we were talking about by supply chain vulnerability. Our group has been actively working on this issue for several years. We have a group, the Resilient Drug Group study that we're doing that is all about understanding the availability and access to life-saving drugs. For example, we've identified 156 drugs used in this country and other high-income countries that literally, if they're not there, people's lives are in jeopardy. What's on the crash cart? What's in the ambulance? What's in the intensive care unit? What's in the emergency room? And when you look at those 156 drugs, 100% of them are generic. If you look at most of them, they're primarily manufactured in India and China. Because they're generic, there's no big cache of those drugs sitting somewhere. It's almost just-in-time delivery. In some cases, it's a situation where companies aren't even making them anymore, even though they're so critical, because there just isn't a big profit motive in those drugs. There's an example where it's all about national security. I mean, our military, our government leaders are using those same drugs as everybody else. And I think people are finally realizing for the first time vulnerability and what it means and what's the price you pay for having that vulnerability. When you look at the military and you look at the military industrial complex, they pay a great deal of money to keep operations, quote unquote, warm, meaning manufacturing capacity for things like missiles, et cetera, even though they might not make them for days and months on end. When they need them right now. And so that we have not adapted a similar kind of model to the needs that we have in this country for what do we do if we need these drugs? What are we going to do? We're just going to let people die? We've already seen drug shortages become a real challenge during the COVID-19 pandemic. While it's not a drug, you're watching this very thing happen right now in California, where oxygen supplies have been incredibly low, where people have just not been able to get oxygen, which has been critical to keeping them alive with COVID-19 because there just isn't enough. So I think that the challenge we're going to have here is identifying how do we have a new business model. And I believe that in the critical drug shortage side of the house, we have to say, these are so critical. We will pay to have capacity here in this country. We will pay to even keep it warm, meaning if it's not being used in 100% capacity, we'll pay to make sure that when we do need it, it can immediately be geared up and do what we need to have. So I think this is a huge issue, and it's one that, whether it be drugs, whether it be other medical supplies, whether it be PPE for N95 respirators, ventilators, whatever, this is hopefully going to raise these issues to a very high level. And I'm confident, just from my work with the Biden-Harris transition team, that these will be items that will be front and center on the agenda for this incoming administration.
Thank you. That's great to hear. So do you think that means just creating more stockpiles, like you said, or does that mean maybe moving manufacturing to the United States? How do you see that happening?
I think it's a combination of both. I think part of it is just diversifying the concentrated manufacturing that now occurs in India and China. In some cases, 1 or 2 plants supply the world with a given critical drug, for example. You're already seeing that. I think several years ago, the world was really made aware of this when the Bangkok area had major flooding. And it turned out that an industrial park there was flooded. And guess what? 50% of all the world's chips for their laptop computers were made in that industrial park. And it shut down half of all the manufacturing capacity in the world for chips. Well, that following Christmas, there were a lot of people who didn't get their Christmas gift of a new laptop because you couldn't get them. And they realized the vulnerability of placing all that in one place. So that it is a challenge. And we have to understand, if you don't put it all in one place and try to simplify and leverage the advantage of, having centralized production, shipping, all those things come to play, you have to pay more to have it done in multiple locations, multiple plants. And how do we handle that? Is the free market going to cover it? I don't think so. So one of the challenges we're going to have is going back and understanding and ascertaining what is essential products that we need for everyday life, and how will we go about assuring that they'll be available.
Thank you. Thank you for that answer. I want to shift the conversation towards the vaccine, because I know we have a limited time with you, so we want to try and get all of these questions in. And I don't know if we said this before, but these questions they're not just from us, but they've been submitted by students from our whole college, people who couldn't be here. So the next question is, how do you think society or the government should address the growing population of people who have expressed disinterest or hesitancy in receiving the vaccine?
Well, first of all, it's really important to understand that what Operation Warp Speed has been able to accomplish with the research and development, the studies, the efficacy-related studies, the lab safety studies, and the submission of all this information for emergency use authorization in the time frame that's happened has been simply remarkable. It is really a Manhattan-like project in the vaccine area. Having said that, Operation Warp Speed really focused on everything up until that last mile and that last inch. And what I mean by that is that they made vaccines, or getting them out, but no one really concentrated on how do you distribute these vaccines in a community where it's a difficult vaccine to administer. For example, if you take the Pfizer vaccine, you've got these very extreme freezer conditions you have to maintain until you pull it out of one of those freezers. It's good for 5 days in the refrigerator. Once you reconstitute it, it's good for 6 hours. And do you know how difficult it is to use that kind of a vaccine as you're trying to vaccinate across large populations, some cases remote populations? That's a challenge. And so what we haven't done is really told the public a story. Operation Warp Speed, what a terrible name. It makes so many people conjure up ideas that, that safety was not a priority. It was about speed. And that just simply wasn't the case. Every safety evaluation and safety measure that we would take with any other vaccine was also taken with these. And so from that perspective, I'm very confident in what we know about the safety of these vaccines. But we haven't told that story. Next, we have a vaccine. Right now, the two licensed products are both what we call messenger RNA vaccines, new platforms. They've been used before in the sense of research, or a number of different areas have been looking at messenger RNA vaccines for the last 20 years. Some of our best vaccine work with cancer has been with mRNA vaccines. But nonetheless, most of the public doesn't know that. All they know is there's something about a genetic thing going to be inserted in me. And that's not even a true statement, but it turns out that, in fact, there's a sense of some kind of a takeover of my own body's genetics. And again, we haven't told that story. So I think that the public necessarily has a really skewed view of what this is all about and why these vaccines are so important. So we have to do much, much more about that. And that will basically then fall under the what I call the last inch issue, is getting the needle in your arm. How do we reach out to populations that have been disenfranchised? Even healthcare workers. We're seeing up to 40% of healthcare workers today are hesitant to take the vaccine now. They're not saying they won't take it. They're just saying, let's see if there's more safety data coming out. Well, I can tell you right now that they're putting their lives at risk to dying from this virus or that of a loved one. And so what we have to do is, again, help them better understand why these vaccines are so important and why they want to take them. And we haven't done that. We're going to have challenges in some subpopulations in the Black community. There's a lot of distrust for vaccines. And now imagine a military-related vaccine called Operation Warp Speed. Can you wonder why people might be concerned about them? There was all this discussion back last September and October about the political influence on approving these vaccines, getting them out before the election, kind of thumb on the scale. None of that happened. I can assure you that the FDA review of these vaccines was as good as any review has ever been done of a vaccine. Comprehensive, brought in outside experts who really went through everything. Yet we haven't told that story. So I think that at this point, we have to do a much, much better job of understanding the knowledge, attitudes, and beliefs of the public out there, who are many and varied. And how do we reach them? Reaching healthcare workers in LA County may be very, very different than trying to reach young Black men in rural Georgia. And so we've got to figure out, how do we best do that? It's not just putting up a billboard, say, get vaccinated. It's not just, having a 30-second PSA saying, get vaccinated. It's trying to understand, why are you not? What are the challenges? And that's what I hope we're going to see more of in the next few months, is people are trying to understand that, and then promoting that piece of it, and working with the public and various occupational groups why they want to get vaccinated.
Thank you. That was a very thorough answer, and you kind of went into the next question that someone asked, and that was, how do we ensure that these vaccines are distributed equitably? And I think you kind of went into, it's different in LA versus Georgia, especially when you're comparing the demographics. Do you know if there's an effort on the national level to kind of address those populations who maybe don't typically receive healthcare as equitably as others? Or is it going to be more on the state level?
Well, I think right now we're undergoing you might say, a real discussion about how to deliver these vaccines quickly. And the challenge is, if some populations are going to be reluctant or hesitant to take the vaccine, how much time and energy do you spend in that population before you move on to another population that is willing and ready to take the vaccines? So you get more and more people vaccinated. And that's what's happening right now. Is initially we started out with long-term care and healthcare workers. That has necessarily been slow. I should say it is slow. I won't say necessary, actually, because it was not well designed by the federal government to do what they were supposed to do. The federal government hired 2 pharmacy companies to basically deliver the vaccines in long-term care, and they were not ready for it at all. Not at all. Been very slow uptake. If you look at healthcare workers, the same thing. You got the challenge of trying to get the vaccine into hospitals where they're already under siege, just trying to take care of patients. And you've got to space out the vaccines because we do know that they have some local reactions that can occur where, the next day you may not feel that well after getting the vaccine, which is actually a great sign the vaccine's working. But at the same time, if you're trying to staff a very, very busy intensive care unit and you're razor thin on your staff complement, that's going to be a real problem if you suddenly take, 10, 20, or 30% of the workers can't come in today because of a sore arm. So they've necessarily had to spread out the vaccinations too. So, but people have interpreted this to mean, along with holding the second dose, so it's available 3 to 4 weeks later, that vaccine's just not moving fast enough. Well, the truth of the matter is it is based on what we just shared with you, but it's going to get a lot better as we get more into the community and state and local health departments get much more involved. Resources are going to start flowing to them soon where they can start setting up large community clinics. Now, the challenge with that is, again, will you have enough vaccine to meet demand? And yesterday, the current administration put out a new recommendation, basically said, 65 and older and anybody that has an underlying health problem. Well, that was tough because we want to have enough vaccine for that combined population for months. So now it's just created more chaos about who should get it. Imagine this right now, based on the criteria, if I'm a 22-year-old smoker and I stay at home, I don't leave my home, I'm still eligible to get the vaccine at the same priority as somebody who might be 55 or more and who doesn't smoke or doesn't have underlying health problems, who might have to go to work every day in a grocery store. So I think you're going to see a lot more turmoil about recommendations, who should get vaccine when, and just know we're not going to have enough vaccine for this country, even if we don't have everyone take it well into the summer. So I don't care what recommendation you put out right now. I don't care how you try to do outreach. You're going to have a challenge just because we don't have enough vaccine. And that's going to be all about production. And at this point, we can only hope the production doesn't run into any roadblocks. That'll be really key.
Wow, thank you. That's all kind of crazy to hear because, yeah, that's crazy to hear. I'm going to pass it on to Willa now so that she can have a chance to ask you some questions.
Thank you.
Thank you.
Kind of shifting gears a little bit. I know you briefly talked about this earlier with just America's preparedness compared to other countries. So I wanted to ask, in what ways do you think that American culture has played a role in our country's preparedness and the response to the pandemic? And how do you think we can learn from our mistakes?
Well, there is no other country like the USA right now worldwide in terms of the political strife, the challenges that we're seeing with a pandemic on top of all the political issues. I mean, as a high-income country, the longest standing democracy, we've been challenged. And so I would say that there clearly is an overlap between the events of now from a political standpoint, an economic standpoint, and what's happening with this pandemic. But make no mistake about it, pretty much most of the high-income countries of this world made a lot of the same mistakes we did. Look no further than Europe right now. Europe's in big trouble with this virus, particularly the new variant strain that just has emerged in the United Kingdom. And you're seeing, in London, Ireland, places like that, just horrible situations with the rapidly increasing number of cases. We're seeing it in parts of Africa right now. A major increase in cases has occurred there just over the past month. After a long time, people assuming, well, there must be something about Africa that makes it safer here. Nope, virus is here now. And in fact, in South Africa, it's one of the worst places in the world in terms of, again, a new variant of the virus and what that might mean. Brazil, etc., all of them are having problems. So when we assess the U.S. capacity, we have to look at the whole world and just say, did we do something so different than the rest of the world or not? And we can surely say, well, look at the number of cases we have. We're out there really of any major country in the world. We stand out in terms of number of cases, number of deaths. And I think that does come back to our individualism, the fact that we have a growing segment of our population that, public health be damned, I'm going to do what I want to do. And we have not accepted the fact that, by wanting to live life as we've always lived it. This is what's going to happen, increased transmission, and we're going to be in trouble. So I think from that perspective, we are at risk in a way that other countries might not be, but we're not that different. When you go look at what's happened in Germany, you go look at what happened in Sweden, Norway, Denmark, look what's happened in Spain, look what's happened in as I mentioned earlier, the Milano region of Italy, that area. It's a real challenge. So we surely have lots of lessons to learn. As I pointed out, I don't know when we're going to think we're beyond this pandemic. I hope sooner than later, but I don't know. But when we are, we're going to have to go back and kind of make the assumption that this was like a plane that had 600 black boxes on it that went down. And we need to analyze every one of those black boxes to make sure this never happens again.
Great, thank you so much. I think Mallory now has a question for you.
Yeah, so my question is about science communication. So we've seen with this pandemic that data accessibility and public buy-in have been really difficult, and a major issue with that is a belief that science has become very political. So what steps can we, as people going into healthcare workers, and just people generally interested in public health and education, what steps can we take to make science apolitical again?
Well, I don't think you ever can. I don't think that's like saying, how can we do something to make sure hurricanes don't happen anymore? We can better prepare for them, but I'm not sure that we can do anything to make them not happen. The world is what it is. And in a world of modern social media, we live in a new place. Before social media, to further these, very outlandish and just unrealistic, stories, conclusions, misinformation, disinformation was a lot harder to do. Today, it's much easier. We're watching that in our country right now unfold. And so we're all struggling with this right now. When we talk about vaccine hesitancy, we used to have a situation where there was hardcore anti-vaccine people that made up a small percentage of our society who basically, nothing was ever going to change their mind. They had an answer for every scientific issue that, of course, was wrong. In fact, it bared no merit at all. Now, today, we have a growing body, particularly of younger adults, who are suspicious of things like vaccines. And it's not the same level of anti-vaccinology. It's not that they just don't believe in vaccines, but they're very skeptical about what they will do or how they would do it. And if I've heard one, I've heard hundreds of parents say to me, well, I'm not going to have my child get that because we just don't quite know what that will do to them. Well, I know very well what will do something bad to them, and that is getting the actual infectious disease that this vaccine is going to prevent. Yet that plays no role in their decision-making because somehow they haven't seen it. They haven't experienced it. So all they think about is the one side of the equation is there 1 in a million chance that my child could have a serious reaction to the vaccine? I'm not going to get it. Even though there's a chance that, 1 out of 100, your child could have a very serious life-threatening disease from not being vaccinated. So I think that we have to go back to the drawing board, and it's no longer just about providing information. Those of us in education, I think, have for far too long had a certain arrogance about the fact that if we just educated people, we could change their minds. That's not true. That's just not true. Who would have ever thought a few years ago people would be talking about alternative facts? The term alternative facts. I mean, that seems ridiculous. That sounds like a very warm, cold day. What does that mean? And so now we are confronted with that. We have to go back to the drawing board and say, how do we help influence the way people think about vaccines or how they'll use them? I go back time and time again. It starts at birth. If you are trying to influence someone in junior high or high school, that's way, way, way too late. They've already been there. It's like religions. By the time you become several years of age and your household practices certain religions, etc., you naturally are aligned in that area. That's what you tend to do for the rest of your life. That's the challenge we have today, is how do we get to families where vaccine hesitancy is real and somehow work to influence their children to be the next generation that are not vaccine hesitant, with at the same time respecting the family's, sanity here, and saying, I get to do what I want to do. You can't come in and tell my children they have to do this or that. So I think we have a real challenge. I don't know what the answer is. I know that we need to look at it. I've been one of those people saying we need to bring the best and brightest minds. We have to study this in a way that says, what is it that can influence people? And I don't know right now.
Thank you for that answer.
I think you brought up a good point about social media and the power, the role that it plays on information. Do you see just any way at all in how to fix that in terms of social media and medical misinformation? Will it be legislation, or what's that going to look like?
Well, I think right now we're all examining what constitutes, misinformation or disinformation, and what, the freedom of speech is versus, what is dangerous. And it doesn't get protected by freedom of speech. And I think we're seeing that right now at the end of this presidency, that we're having discussions with, the Facebook, Twitter, all those that had not happened like they're happening now. So I think one of the challenges we're going to be dealing with is in misinformation around health issues. What is the guidance? What is the authority? What is the action that will be taken to deal with clear-cut mis or disinformation? It's like the whole issue with Andrew Wakefield, the physician from England, who clearly just lied about the issues of autism and measles vaccine. And, it was found that he did that. And that's why he was basically, his medical license was suspended. And yet that study, which was done years ago, hangs on, and he still is a voice out there in the community that people just flock to, almost like some kind of health messiah. How do you deal with somebody like that has convinced people that in fact he's right and the rest of the world's wrong, and in the process has caused many children not to get vaccinated against measles? And unfortunately, far too many of those children have gotten severely ill, and some have died. So I think the challenge we have today is actually asking ourselves, how do we deal with all forms of mis or disinformation? How do we use social media as a friend to help us share the correct information, at the same time limiting dis or misinformation? And again, I think we're at the forefront of that issue. I would never have imagined just a few months ago, based on the past 4 years history, that any of these social media sites would basically bar the current president of the United States from being on the sites. Yet they are. That's a big change. So I think that's what we're going to be learning from, is how do we deal with mis and disinformation? And I think we should really reconsider what we've already done as having been terribly incomplete, and what we need to do.
So I have a quick question that's kind of related. So you mentioned that obviously misinformation is, as you said before, it's really bad, and it's pervasive in this country. And I think a large part of why it's happening is because of a lack of science literacy. So do you have any ideas about how we can improve science literacy in, as you said, in earlier education than now?
That's a great question too. You all have great questions here. I think one of the challenges we have is knowledge, attitudes, and beliefs, which have nothing to do with science as such. What I mean by it's not about facts. Why do people believe or feel things? What do they know? Meaning that their knowledge is more than we just teach them science. But what is the collective community-wide contribution to what they know? And we've not done a good job understanding that. I can tell you right now, even with trying to roll out this COVID-19 vaccine, has been a real challenge, in part because we don't really understand the knowledge, attitudes, and beliefs of the people we want to get it, who might very well differ from what we perceive them to be. And so the first thing we have to do is really try to understand what goes on. I've had the good fortune to work with a group at the University of Maryland. And there's an outstanding public health professor there, Stephen Thomas, who has formed a group. Basically, it's the Maryland Black Barbers Group. And it's a group that is just, to me, one of the finest examples of public health on the forefront. They've enrolled these barbers who basically are in the heart and soul of the Black community, particularly among young Black men. And they're empowered with information about health. They have wonderful conversations with their clients when they come in to have their haircut. And they have become really important nodes of providing reliable, timely, and authoritative information into the Black community, particularly Black males. And it is such a different world than if you and I were in a classroom, or we might be in some community like my home community in Northeast Iowa, where I was born and raised. It's a situation where it's so different than what, I would experience if I were in one of these barber chairs in Maryland. And I've been to these places in the sense of having talked to these individuals and working with Professor Thomas on this area. And it is something that I have had to learn. I mean, I've been in this business 45 years and I think, well, I've seen everything. Okay. I haven't. So one of the things we have to do is take a step back and say, what are the knowledge, attitudes, and beliefs of the public out there? And don't assume you know. Understand it, learn it. How do you learn it? You have to talk to the people there. Once you have that, then you can start saying, so then how do we insert scientific literacy into that? If I have this absolute belief that the US government is out to get me, I don't care what you tell them that's science. I don't care if you tell them that if I drop this rock, it'll go to the ground. They don't believe in gravity if I think it's government sponsored. And so why did that happen? Well, go back and look at Tuskegee. Look at the experiment that was done on Black prisoners with regard to syphilis. That's a residual that will last forever. So how do we deal with that? Once you understand those things, then you can start to really approach science literacy. And so I urge people not to just jump to the fact that if I get the next best billboard, or I have the next best PSA, or I have the next best ad, or I have the next best slogan, that somehow I'm going to change people's attitude and beliefs. Not going to happen. You've got to engage them where they're at. And frankly, the last thing is, you know what? I'm an old white male. I should not have a lot of credibility necessarily in some of these communities. I can help. I do know a few things, but I have to understand that the people who can do the most good are people like yourselves. The diversity I see right on this screen. You represent what it should be about. And it's more than just teaching science. It's about understanding. It's about empathizing. It's about getting under the hood of the attitudes, knowledge, and beliefs car and trying to figure out what's going on in there. Then let's talk about how we deal with science. So you're our future. I mean, I look at this screen. I'm so glad to see, the diversity here. It's wonderful. This is the future. That's where science literacy starts, is right here.
Thank you so much. I think you made some really great points about, first, the importance of understanding the history, first of all. And I think that really aligns with the theme of our conference, where it's not like these issues are not new. They've always been there. And COVID is just exposing them.
Yeah.
So I think that's a really good point. It's just the importance of understanding the root of the issue and then starting from there and building back up. So thank you so much for that.
And you, by the way, just you said that very well. You got it.
Yeah.
Okay. So run with it. Okay. I'm expecting you to now to be part of the solution. Okay. You're part of it now. Okay. You get it. You can't get off. Okay. You got to deal with it.
That's why we're all here. We're all just trying to figure out how to do this. And we're part of our class. We've got some really young medical students and just students in general who are energized and are willing to help and be a part of the change. So again, we're just really thankful that you took some time to come talk to us today. So with that being said, I'd just like to move forward and talk about a different aspect of the pandemic, because we see all the physical part And I think in the past maybe decade, an important thing that's come up in medicine is the issue of like mental health, and how like we're focusing a little bit more on that than we used to before. So and that's not just talking about the patients. That's talking about like the healthcare, the frontliners who are out there, the potential PTSDs and the anxiety and depression that came with this pandemic, and just like all the stuff, including like income insecurities and stuff like that. So I just want to get your thoughts on how do you think COVID-19 has affected the mental health society, and how can we move forward? Because I feel like I know you said when this is going to be here for a while, I feel like with the vaccine, we're getting closer to a little bit better time. But I feel like once the physical aspect is done, it's going to be dealing with the mental aspect of COVID-19. So how do you think it's affected the mental health community, and how do we fix that moving forward?
Well, first of all, let me just say this is the trillion-dollar question of this pandemic. I'll address what's happened to date, and then where we go forward after that. I don't know if I have any more tears left. I've cried so many tears myself over the course of the past year. I've had many conversations with frontline healthcare workers who have suffered immeasurably from a mental health standpoint, post-traumatic stress. You know, we have over 1,700 healthcare workers in this country who have died from COVID-19. You know, surely not all of them acquired the virus working, but a number did. And the racial disparities issue is very prominent there. The people who don't just work at the bedside as doctors and nurses or lab technicians or respiratory therapists, but environmental services, the people who are the ward clerks, the people who are the nursing assistants, the people who make sure that people are located in one location to another in terms of movement. These people all too have often also suffered, and often have been disproportionately from the Black, Indigenous, and community of color populations. And so I just want to emphasize that part. And actually our group, this started with a crazy brainchild I had, started the Frontline Families Fund, which is a effort of the Minneapolis and the St. Paul and Minnesota Foundation, as Brave a Heart Foundation in New York, to actually raise funds and distribute them to the families of healthcare workers who have died. Immediate money is made available, particularly for those families who don't even have money to bury their loved one. Far too many healthcare providers, single parents with young kids who left them behind almost nothing. And so we've now raised almost $2 million with the Brave a Heart, multiple millions there. And we're working hard to distribute that money to cover the immediate costs. And for those who have a financial need, who are not well off, who didn't have a 7-figure insurance policy to leave behind, that these families can also get additional support going forward. Finally, we've also established a college scholarship fund for all the children of these healthcare workers. It doesn't matter whether you're 18 years of age or you're 1 year of age. We want you, at the time you want to go to college, that you have that opportunity to have that scholarship. So from that standpoint, we can't change what's happened to these healthcare workers. We can't do that, but we can do something. And so this fund is surely one that I urge anyone here listening to this, the frontlinefamiliesfund.org. We are putting all this money directly back to healthcare workers' families of those who have died. So that's one plug I want to get in and say that that's something that we can all do something about. I think the second piece of it is, as you just pointed out, the post-traumatic stress is remarkable. We have not provided anywhere near the mental health support that we need to for healthcare workers who have just day after day gone to work 16-hour days just trying to save people's lives, and then watching them die and die and die. I had an intensive care physician a military trained emergency room intensivist from the military, been to the theater of war twice, who one day shared with me as he broke down in tears that he couldn't do this anymore, that in fact, he had just been part of, for the fourth time that day, using an iPad to show the face of a family loved one to the families who were necessarily outside because of infection control reasons as they watched their loved one die. Do you know how much that cuts into the very core of what you're all about? Watching your colleagues become infected and die. So we've got to do much, much more. And this is not going to go away after a pandemic may somehow be impacted by vaccine. This is something we owe healthcare workers in the front lines to deal with this. Mental health is so, so, so important. Every bit as important as any physical health. And so I hope that the medical community, not just in this country, but around the world, understands the challenge that this provides and why mental health support needs to be there on an ongoing basis. I said I'd talk about what's happened to date. Let me talk about what's going forward. We're all really tired of this pandemic. The fatigue is absolutely palpable. We have also clearly pandemic anger going on where people don't want to believe this pandemic is real. They're just tired of it. They're financially in terrible shape. They've lost jobs. They've lost their homes. They don't have enough food. 1 out of every 8 families in this country right now today are in a food shortage status where they don't know what the next meal is going to be for their kids. Think of that. They don't know. And so we've got to understand that going forward, we have to change things. But I'm sitting here today telling you I worry a lot about this virus and the mutation changes that are occurring. And we're still trying to determine just how effective these vaccines will be long term. And I think there's a real possibility that we will be dealing with this pandemic for a number of years to come. Now, it won't be the same necessarily as today, but we have to understand, we have to adapt to a whole new way of thinking, a whole new way of understanding and feeling about this virus. And right now, I worry that everyone is so set on by summertime, we'll be back to normal. That if that doesn't happen, and there's a good chance it may not, people will in fact implode. It's like, I can't do this anymore. You know, the person who was told they needed to walk 100 yards, 5 miles later, they're told it's just another 100 yards. How many times can you do that before they just collapse? So I want to just leave this. I don't want to leave it on such a down note, but we are resilient. As humans, we're resilient. If we understand what we're up against, we provide us with the resources to deal with it, we can make it. We will make it. I would say if I had one last piece of advice on all of this, and I do a weekly podcast, the Osterholm Update, and I have been urging since the beginning of my podcast almost a year ago, I do them on a weekly basis. What we need right now in this country and around the world is a competitive pandemic. Our pandemic is a pandemic of kindness. You know, today, do something kind every day. It doesn't matter if it's really simple. Just do something kind every day. You know what? You probably get more out of it than the person for which you did the kind act for, because it just puts you into a mindset that says, instead of being angry, instead of being scared, instead of being tired, instead of being in a place where I don't know where I'm going to go next, start figuring out how you can be nice, how you can be kind, even if you're in pain. And you know what? That's the start right there. So I hope healthcare in general, all of you who hear this, every day, one act of kindness. That's all you got to do. And watch what it does. So to me, that's another part of dealing with this post-traumatic stress, acknowledging it, supporting all of these individuals to get the kind of mental health support they need, and do an act of kindness every day.
That was a great answer. Just moving forward, I know we're running out of time with you. And again, just thank you so much for taking your time. I think this next question, just your answer earlier was just really good. And I feel like you answered some of it about just doing something, right? So I think this is the most important questions for conference comers is what are some tangible things that we can do, especially as students, because I feel like a lot of our conference comers are going to be students. And I want to emphasize the word tangible. What are some tangible things that we as students can do to help address the disparities exposed by this pandemic?
So I suppose by tangible, you won't let me say to you, change the world. That's not on the agenda. Okay, well, I'll skip that one then, okay, and move into something else. You know, you have a lot of power as students. Get involved. Be bigger than yourself. Volunteer at vaccine clinics. Volunteer at a food shelf. Volunteer at a shelter. Think bigger than yourself. And when you think bigger than yourself, you become big. You become very big. Be kind. It's going to be tight. I'm telling you, being a student right now in this area is tough. You know why? Because it is so tension filled. There's so many sad moments. Hold a patient. Hold a family member. Hold a colleague. Don't be afraid to express yourself. Be there for them. Those are tangible things you can do. We're all human. I don't care if you're the biggest shot in the whole place, you know. You still put your pants on the same way. You still hurt. Be kind. Be good. Those are tangible things you can do right now. Second of all, get involved. Do get involved. Volunteer. Find out how you can make a difference. And you will find many ways to be able to do that. People are looking for that right now. And that'll bring such purpose to your life. That'll bring purpose to your life in a way that you may not have ever had. You know, it's not about learning all the facts. It's not about having some, you know, very sophisticated knowledge of some kind of physiologic phenomena that for which now you are the expert at the bedside. Become an expert of the heart. But the kind of heart I'm talking about is the kindness heart. Just do that. That's not going to make you smarter in terms of the facts. That's not going to make you somehow do a better in your class grade. But I'm telling you, it'll make you a hell of a lot better person. And it'll make you appreciate the job you're doing in a way that you otherwise wouldn't have appreciated it. So I guess I leave you with that fact. Those are tangible things. Those are real, tangible things that you can do. And now's the time to do them. We need those more than we've ever needed them before, and every one of you can do them. So that's how I leave it. That's tangible. And if you change the world in the process, that'd be okay too, okay? So do that if you can.
Thank you so much. Jen, do you have anything?
Just thank you again, Dr. Osterholm, for spending time with us today.
I hope this was helpful. I don't think I imparted all that much knowledge, wisdom, whatever, but I hope for all the students, I wish you well. And, you know, we need you. Boy, do we need you. We need you so much. Thank you.